I wonder if you can all hear me all right. Can you see me all right? Please say hi in the comments. I can see 5 of you and no one's commented. All right, I'm going to start from the top because I'm not sure whether any of you heard that. So welcome to another Vulval Pain Society Live. Thank you for joining us live or watching on the replay. If you are watching live, please say hello in the comments. Our guest is happy to answer your questions at the end, so put those in the comments box. Please say hi in the comments. I'm Sheren Gaulbert, Vulval Pain Society Trustee, pain therapist, clinician coach, and pain science educator. Last September, hello everyone. Who else is there? I can see 7 people are watching. Hi, Marion, nice to see you. Lovely. And do keep saying hello. I just want to make sure that our tech issues are over. So last year, you may remember if you're watching, if you haven't watched this, please catch up with it. We'll put a link in the comments after our live has finished today. Researcher Athena Louncey, she revealed an average time to diagnosis for someone living with vulval pain was around about 2 years, and the stumbling block was often at the GP surgery. Today, we have a message of hope. We're going to hear from a GP practice who have very, very satisfied patients. They are the #1 top-rated, Google review top-rated GP practice in the UK. So very satisfied patients. And of course, this is a GP practice to be modelled. We want to know what they are doing and how they're doing it so that patient care is enhanced. So please welcome our guest today. It's Dr. Sheikh Mateen Ellahi. I hope I'm pronouncing that correctly. Hi, Dr. Mateen.
Hi, Sheren. Thank you for inviting me. Hi, everyone who's watching live and obviously on replay as well. Nice to meet you all.
Thank you so much for joining us. Your practice is doing something really special. Now, for those of you watching for the first time, my eyes are going to be darting all over the place because I've got a number of things I'm doing. I'm keeping an eye on the comments, keeping an eye on Dr. Mateen is going to be sharing some slides, and just make sure that our tech issues are over, right? So don't be concerned, everything's fine. Now, you're doing something really special, Dr. Mateen, at your GP practice, Elm Tree Medical Centre?
Yes.
First of all, before we dive into your slides and the medical centre itself, I want to hear more about you. Tell me about you. What's your background? How have you come into this?
Once again, thank you for inviting me. Happy to talk a little bit about myself. I don't want to kind of harp on about what I've done, but briefly, currently I'm a GP. I always wanted to do medicine, always wanted to become a GP really, and because of my 3 passions are essentially medicine, teaching, and business, and I felt the easiest and the best way to kind of have all those 3 passions in one job would be becoming a GP. So I became a doctor 10 years ago, actually last week. So it's only literally been a decade, and the quickest way you can become a GP is essentially within 5 years. So I became a GP 5 years ago. And then I became a partner. I always wanted to become a partner because of the business mindset. I wanted to have impact rather than nothing wrong with being a salary GP, but I wanted to kind of have my own ideas put across. So yeah, became a partner, and I moved to my practice about a couple of years back. So we're doing really well, and I think we're growing really, really, really quickly, primarily organically as well, just word of mouth because of the access we provide. And I think one of the things you mentioned earlier on is that a lot of people with vulval pain can sometimes find it difficult to get diagnosis. And the prime thing, in my opinion, in primary care is getting access. If you don't get seen, well, you can't get diagnosed in the first place. So I think access plays a huge part in this. And I think one of the biggest things we've got is we've got the access correct. So if you phone at 8 o'clock in the morning or 4 o'clock in the afternoon or 5 o'clock, you will speak to someone the same day if you want to, obviously. So we're doing really well. And all the other things I'm doing a bit of teaching. I'm teaching lead in the PCN, where we have 60,000 patients, and doing a bit of minor surgery, joint injections, and I recently completed my MBA, so I kind of fulfilled my business aspirations as well. And because of all of that, I'm now doing a bit of consultancy work with a couple of wonderful people.
Wonderful. Brilliant. Lots of achievements there. And congratulations on the 10 years.
Thank you. It doesn't feel that long. It feels like yesterday. I remember
you look very young, so I don't know what you're doing, but tell us about it. No,
I'm not
tell
doing
us
anything.
about Elm Tree Medical Centre.
Yeah, happy to talk through a presentation. Is that okay?
Yes, yes. Give us your presentation.
Let's do that. So I will share my screen. Bear with me.
Once that's shared, if you can tell us in the comments that you can see it live as well.
Yeah, if you can tell me, Sheren, if you can see it.
Okay, I've added it to the stage. I can see it. Can you see it?
I can see it. If a couple of people can comment, I can't see the comments at this stage. I can only see my presentation. So if you can let me know if people.
So let us know that you can see the slide, the opening slide, Elm Tree Medical Centre. Yep, can see. Let's go.
Perfect. So yeah, Elm Tree Medical Centre. I'm Dr. Sheikh Ellahi, and we're in Thornaby, which is a very not well-known area in the Teesside in the northeast. Unfortunately, one of the most deprived areas in the UK. I mean, there's a street next to us, very close to us, which was on TV a few years back as one of the most deprived areas in the UK, really. But yeah, so introduction. I'll talk briefly through what I've done in the past. So yeah, went to York Medical School, did GP training, and those are some of the few things I've done. And I love sports. I love watching sports now rather than playing. But any opportunity I get, I try and play as many sports as possible. So what I want to put across today, and obviously, people might be watching this in a few years' time, a few months' time, is the NHS model. And I'm only doing this for people who are possibly not in the NHS sector to make them fully understand how primary care in the NHS actually works. So I want you to imagine NHS as a quick fit. Quick fit in the UK here is essentially a mechanical shop for cars or any vehicle really. So imagine a government was funding, paying a yearly fee of £130 or £250 to your local garage for each customer they had acquired on their business. But the garage itself cannot charge any of their customers to come in to the garage. So the customer can come in 100 times a day or 100 times a month, maybe more realistic, or 100 times a year. Or they don't come in at all, but the garage get paid that fixed amount. All the expenses of the garage, so you're talking about staff, electricity, gas, water, equipment, renting the place if needed, would be served by the garage itself. As I mentioned, it would have unlimited access. So you as a customer can visit the garage as many times as possible for any reason at all, whether it's an oil leak, whether it's an MOT. MOT, just to clarify, is just a yearly check of your car or motorbike or anything. Or you could even come in if you think there's possibly nothing wrong with the car, but you just wanted it checked over anyway. So like you wanted the car being washed and you come in asking for that. Even the quick fit doesn't do that. So there's no self-service required. You don't have to do anything yourself. Everything from windshield cleaning to major repairs will be included. And you just walk in and you kind of ask for it as soon as possible. There's no refusal system. So the quick fit garage or here in the GP center, you can't really refuse anything. If you're short staffed, if you're lacking parts, etc., it's your obligation because you signed a contract to do as much as possible for that customer. It's always available, obviously between 8 till 6. And if it's urgent, if you feel as a customer it's urgent, then you might feel that it needs to be sorted the same day or the same minute, if possible. Often mechanics, because of the unlimited access that the contract can seem like to the customer, mechanics don't work 8 till 6. Mechanics that end up working 10 hours, 11 hours, 12 hours, especially the managers who are overrunning the business. Sometimes people will come in, despite as I mentioned, despite the garage specializing in cars, people might come in to fix other things. And I'm being a bit cheeky here, but bikes, lawnmowers, washing machines, etc. So other things other than the cars. You have external demands as well. So the employer or NHS or your local organization who employs the garage can tell you what to do and give you extra money as well for other things you might be asked to do for the customer. There will be angry customers because they will ask for certain things which are unrealistic in unrealistic timeframes as well. And there's often staff shortages. Sorry, not only because there's workforce shortage in the NHS or in the mechanical aspect in the UK, but also because people are stressed. People have, unfortunately, in the medical field, you can have high suicidal rates, and more people are going to other places in the world because they have, or they perceive to have, better work-life balance. So now that I've given you kind of a background of the NHS, I want to talk a little bit about Elm Tree Medical Centre. So we are 12,000 patients, currently just over 12,200. We have built our own state-of-the-art building, which we own ourselves. We have 5 partners, 3 of them are clinical and 2 are non-clinical. We have 3 salaried doctors who we employ, 1 advanced nurse practitioner, 1 paramedic, and roughly we are roughly have around 50 staff working for or with us at Elm Tree Medical Centre. We're also very, very big on teaching. So we have affiliations with local university, where we have students registered with us, but also more importantly, we teach from 2 or 3 different universities locally, and we're wanting to expand that to 4 universities in the future. So this is the funding. I mean, this data was only going to 2022, but some of the data I will talk about is actually related to 2024. So as you can see here, Elm Tree Medical Centre was getting £140 per patient. But you can tell the England average was 161. This is due to a very complicated formula. It can be related to age, ethnicity, the demands of the local population, etc. But even though we are quite underfunded compared to the average in the UK by roughly, we're talking about what, 12-13%, we are still performing exceptionally, which I will discuss now. So this is the yearly patient list size. Now you have to understand that as a practice, your list size grows normally because of the service you will provide. You're not going to go to an MOT center or quick fit if you think you're not going to get in that center to see a mechanic in the first place. So you'll only go there if you've heard good things about them. So this is organic growth. So you can tell that only 5 years ago we were 4,500, just over 4,500, and now we're touching nearly 12,500. This is the actually yearly percentage increase. So you can tell that even though there's a dip to 10%, that's still 10% increase in patient list size while going through COVID. And then the actual percentage increase has continued to go up. So these are the results actually for 2024. We had a 26% completion rate of all the surveys sent out by NHS England. So this is not done by us. We didn't send it to our patients. NHS England sent it to random patients from our list. And 26 completion rate, you may think it's low, it's actually average in the whole of UK. So our results are quite exceptional. As you can see, all the results are nearly 90% or above. Whereas I hope you can see here, if I move my cursor, that's the national average, and that's the ICS. ICS is essentially a local population. Local, I mean, it's quite wide local population. Our ICS is North Eastern Cumbria, but you can tell our results are pretty exceptional compared to the national average or local average. In fact, I think I had a look the other day. I think for our population list size, 12,000 and above, we are ranked, I think, certainly in the top 3, but might be number 1 in the whole of our local area, which is over, I think, 5 million people. And in the UK, I think we're in the top 5. So this is experience in the last appointment. This is the main number you look at here on the bottom left. So this is the overall figure of patients who find our practice very good or fairly good, which is 96%. And if you look at the national average is 74 and ICS is 77. It tells you about healthcare professionals. So how did the patients find their experience in the last appointment? And every score is above 90%, whereas majority of the scores are nationally are early 90%. We are considerably above that. So we also kind of very proud of our DNA rates, and I think because to provide same-day access, I think you have to be very careful that you don't you have very low DNA rates, because otherwise it makes it more and more difficult for patients to be able to see a GP. So our DNA rates are about 30 to 35% lower than the England national average, which we're very proud of. One question someone asked me when I was presenting this at a live conference, actually. Someone said, so Dr. Ellahi, you're doing really well, obviously. Your patients seem to be very happy, but how do you actually measure quality? And it actually made me think. I took about 10 seconds and I asked the same question back to the lady, and the lady really couldn't answer the question. We do have QOF, which is Quality Outcome Framework. So you look at the quality of the service you're providing, but a lot of practices get 100% on that. It's essentially, for example, a patient who's got asthma, do they get a yearly asthma review by a specialist nurse? Or are they using inhalers appropriately, etc.? But it got me thinking. I thought to myself, well, I need to address that question, actually. So I made this slide. So we are 100% on QOF over the last 5 years. However, we don't exception report as we keep it as minimum as possible. Exception reporting is when you ask someone, for example, someone's got hypertension, you want them to get their blood pressure checked. You can exception report them and tick the box to get the mark for QOF if you ask them 3 times but they don't come. But we try and not just do that, but we try and keep asking them multiple times, above 3 times, because we actually want to try as much as possible for the patient actually to have their blood pressure checked, not just to tick a box. We have very high scores on the IIF, which is another quality marker. Learning difficulty or disability reviews should be done once a year normally, and that would essentially, again, tick a box, but we do it twice a year. We have more than 90% of all our medical appointments, rather than, chronic cases are normally handled by nurses. However, GPs do help. But acute cases and medical appointments, we have more than 90% done by GPs. This is extremely rare nowadays. More and more allied healthcare professionals or advanced care practitioners are performing some of the inverted commas easy appointments, but we do heavily rely on GPs because that's what our population and our patients want. We also are very big on asthma reviews. So if someone has an acute exacerbation of asthma, we always make sure the patient is reviewed either by a telephone call or face-to-face within 3 to 5 days to make sure that the asthma is getting better following any steroid medication prescribed to them. As you've seen, we've got exceptional NHS patient survey results, which I feel is a very big quality marker, because in my opinion, the best way to see if a practice or a business is doing well is simply asking their customers. And we have exceptional feedback from all our medical students and postgraduate doctors. So we not only teach undergraduate students who are wanting to become doctors, we actually teach doctors and train doctors to become GPs also. And we've had a CQC rating recently this year, which came out as good earlier this year. Other things we do, we love to collaborate. We don't want just to keep the secret, not that we have any secret, but we want to collaborate with other members of the community and the federation. So we help the local federation provide extra appointments for our local practices when the busiest time of the year comes, which is normally in winter. We also provide ad hoc locum shifts, which is essentially doing extra shifts for other practices to help them with their access. And we were doing this with one practice over the last 9 months also, right? So, so people ask me this question, and they ask, what's the secret sauce? How do you do this? And it's in some aspects is a boring answer. It's not a click of a button, which I can provide that click and everyone will start doing what we're doing. However, this is extremely important. And I think, hard skills such as data, etc., can be not copied, but can be applied very easily. However, these soft skills need time, need energy, and need everyone to be singing in the same hymn sheet, really. And that's the difficult bit in my opinion. So culture is huge. And the culture doesn't happen overnight. So you need to build a culture, and the culture normally always starts with the leadership and the management team, i.e. the partners, essentially. So we are very strong. We have a vision and a mission. We have that on our website. We reiterate that on regular meetings in our practice, from the management to the team in reception and our clinical team. And we make sure we are kind of adhering to it. We have very strict on systems and processes. And I think this is one of the things I brought to the practice a couple of years back when I started. We have systems and processes in place. We have and we do regular audits to make sure we as partners and everyone in the practice is following that. We also like to delegate. So we try and have appropriate staff members performing appropriate tasks. And I feel that actually increases efficiency in our work. And we're very, we like to promote teamwork, but also continuous test to want to improve. And I think that's one of the biggest things. And again, I think this goes back to culture. We as partners are never ever think that we know everything. We have regular coffee breaks every day, and well, one coffee break every day, not regular coffee breaks every day, but and we learn from each other. So even the trainees who are becoming GPs often, have an interesting patient. We share ideas. Someone might specialize in something and shares their management plan or a new thing that they may have learned over the weekend or in the past, etc. So we're always wanting to improve. And I think when staff see that from the partner's point of view, they want to improve in their job also. I think so. I would like to talk about some of the innovations we've done, which I feel are quite unique to our practice. So we have a hub model where you will see, if you go to a medical center or GP practice in the UK, most doctors are in their own rooms and they'll stay there out of 8 hours, probably 7 hours a day. They might come out for eating, maybe a coffee. Other than that, they'll be in their room because they have to do so much work. They have to see patients, etc. So what we did is, because our list size was increasing so quickly, our building, we had to create room. And the only way we could do is we sacrificed our rooms as partners and gave it to our salaried team. And in fact, it actually worked out really well because we made it a hub. Hub is where 3 of our clinical GPs sit together with assistance from an administrative team. And we essentially triage the whole practice appointments on the day. The positives clearly are that you're sitting next to one another, so you're not duplicating work, number one. You're also making decisions very quickly. And if you need advice, you can ask each other literally because you're sitting next to them. The protocols for blood. So if you imagine a doctor on a usual day might spend 5 hours working clinically seeing patients, and then they might work 2 hours a day doing administrative work. That could be looking over letters from hospitals. They could be filing away blood results, looking at blood results, doing reports and other things, signing of prescriptions, etc. So we thought to ourselves, how can we make protocols to standardize everything? And one of the biggest things we've done is actually made protocols for blood results. That not only saves time in filing the blood results, but it also standardizes the work and we make sure that the bloods are filed within 24 hours rather than, unfortunately, I have seen some bloods have been left for a week, 2 weeks in certain practices because of the workload. We have a unique salaried role as well. So going back to the mechanical quick fit, if you are a mechanic, you might like actually being a mechanic, but you might not like the other things. So you might not like billing, you might not like reviewing paperwork of cars, etc. So what we did is, as a doctor, we took away all the administrative tasks away from our doctors who we're hiring as salary doctors, and we just asked them to see patients. That's all we wanted, because that's what doctors want to do, and they don't want to do other things. So, and we took up the role as partners to do all the administrative tasks, including blood results and looking over letters. Again, in our mind, it is standardized work and has made a lot of efficiencies, and the salaried doctors are very, very happy as well. One of the innovations we have also done is teaching. So we teach, as I said, medical students, doctors who are training to become GPs, nurses, nursing associate, and physician associate students as well. And I'm a co-lead of PCN teaching as well. So we've made a model where we share teaching. We have different students or different level of doctors who are training to become GPs coming together and having one session rather than having multiple sessions. Not only does it save time, resources, makes efficiencies, but actually, all these trainees and future GPs or doctors come together and share ideas, share their insights. Everyone learns together. To do that, it needs a lot of planning, but we've managed to create a rota where we're doing that very, very successfully, and our students seem to be extremely happy with us. So that goes along with the joint tutorial, as I talked about. We also do an annual blood check. So any person who normally joins our practice is invited, who's an adult, sorry, with chronic disease, is invited to get an annual blood test. And we have seen that work really, really well. We have an extremely low DNA rate, as I talked about before as well. So innovation. Other innovation is the appointment model. So we have something called unique review slot. So to promote continuity of care. So let's say, again, going back to quick fit, let's say you see a mechanic because of your car, and he thought there was one fault with the car. He tried to fix it, but the car wasn't still working. So you had to come back. You wouldn't want to tell another mechanic everything that's happened with your car, because that might waste a lot of time. You probably want to see the same mechanic. So what we've done is we've made a model appointment system where you get to see the same mechanic, or in this case, same GP. So you don't have to go through the whole history. You just say to the GP, well, actually, this hasn't helped as much. Shall we try option number 2, possibly? It saves a lot of time. The GPs are happier because it makes everything a lot quicker. The patients are extremely happy as well. We're doing room sharing, as I mentioned, in the hub. And we regularly do staff feedback. So we introduced the staff feedback and 360 form. So I had it done actually last month. Thankfully, I got my staff appreciate me, and we go along really well, which is really nice to hear. But we do that for every single staff member, and partners not spared. So we regularly get feedback from all the team for partners, all the way down to reception. So I just want to talk something about barriers to change. Obviously, people can say, well, you made all these changes, but you must have had hurdles. You must have found it difficult to achieve what you did. And can you talk to us about them? So if we're talking about the hub model, what were the barriers? The barriers clearly were that the room was a clinical room. So we had to reconfigure the room. We had to take all the beds out, all the tables out, build 4 computers in there. We had to make sure that there was no loss of confidentiality. So when a patient was speaking to one of the doctors, the other doctor couldn't hear what the patient was saying, and vice versa. So we made sure we bought high-end systems where you are headphones, where you are speaking to the patient and there's no loss of confidentiality, and there was not too much noise that you could hear in the headphone while you're talking to the patient. And the patient certainly can't hear what's happening in the background. Also, we had to fit 4 people in there. So it was a little bit tight, but in our hub model, one of the innovations is that you don't have to knock on the door. If trainees or anyone in the practice needs advice from partners, they just walk in. So we made sure there was a small, 3 chairs or 4 chairs waiting room there. So as soon as one of the doctors was free, most of the time one of us 3 is always free. We can quickly answer any questions to our staff members, so they don't feel like they have to wait or their clinic doesn't run late. One of the barriers to blood and admin filing was essentially the work involved to standardize filing of administrative tasks. If you can imagine how many so we get roughly 200 bloods to review every single day as a practice on average. So to standardize 95% of the blood results, it takes a lot of time to do that, which I spent weeks and months doing, and then to actually make protocols for that to make it efficient rather than involving a lot of team members. Can you make efficiencies so that patients get to know their blood results and a future plan is made, even if there is an abnormal result, saving as much resource as possible. So the time taken and then developing a plan so everyone in the practice was on board with this new system was probably the biggest barrier. The unique salaried role. So as I mentioned, we wanted our GPs to see patients, because this is the feedback we got from the future GPs, doctors who are training to become GPs. They didn't want to do home visits in the middle of the day. They didn't want to be on call. On call is essentially when on a standard day, a doctor might see 25 to 30 patients, but on call, you don't know. You might end up seeing 40, 50 patients. You might end up seeing 10 to 15. So people wanted to know, doctors wanted to know, GPs wanted to know that they come in and they see X amount of people and they can go home. So we took away the on-call, and people don't want to do it. Most GPs don't want to do administrative tasks as well. So we took that away, and we gave all of that to the partners to do themselves, which we're happily doing. AI integration. So one of the new things we're trying to develop is we have made standardized protocols for a lot of administrative tasks. Can we integrate AI automation in a manner which is efficient, but most importantly is patient safe? And we are looking into that, and we've developed a couple of models which are working relatively well at the moment. Joint tutorial. What was the barrier to this? I think the biggest barrier to this is making sure that the tutorials that you're doing for different students and different doctors who are training is appropriate for every single doctor, and it's useful for every single doctor, and is tailor-made for everyone who's going to be present. Also getting everyone on board and making sure everyone is happy with that was a barrier, and it did take a little bit of time, if I'm being honest, but it's working really, really well now, and I think a lot of people are appreciating it. Lowering the DNA rate. I think we essentially, I think we must be unique in this. We essentially employed someone, and most of their work is actually making sure that no one DNAs. And so we employed someone who, if a patient is not on time for their appointment, rather than waiting 10 minutes so they're over their time for their appointment, we start calling patients 5 to 10 minutes before their appointment, or sending them a message to make sure they attend. And our DNA rate has drastically decreased. So we used to be higher than average in the UK on DNAs. Maybe one of the reasons was because people found it so easy to get an appointment with us that if they didn't turn up to their appointment, they knew they could get an appointment the next day anyway. So we made sure that we kind of started reducing that. So we essentially employed someone whose prime job is to make sure the DNA rates are as low as possible. You can't eradicate something like this, but you can lower it, and we've kind of proven that. So recently, as I mentioned, I finished my MBA, and I did my MBA primarily because I felt we can do this at a bigger scale. Yes, we're providing, I believe, excellent care for 12,000 patients, but why can't it be 120,000 patients, 12 million? Or as big a population in the UK as possible. There is obviously a huge gap. A lot of GP practices, unfortunately, are suffering not just to provide the same care, but workforce shortages, stress levels, as I mentioned, suicidal rates in a lot of clinicians, unfortunately. And now one of the biggest things is resources. So with the energy crisis, there's a lot of GPs are complaining and not enough funding. As you can see, there's more and more practices unfortunately being closed down, or their contracts being handed back to the organizations who support them, like ICPs. So the consulting project, which actually I'm working with, I have worked with a large company as well in the past, and a couple of really amazing practice managers as well, is to see where we can make change. And often the consultancy projects are related to practices, unfortunately, which are not doing well, or are seen as CQC inadequate, or which need help. So I've mainly looked at operational side of things. So we normally go into a practice. If they need help, they will know where they need help, and if they don't, then you do a thorough assessment. You work with the team members, the practice manager. You also look at the resources, you develop a budget, you monitor the expenses, and identify new revenue streams. And one of the biggest things I'm very passionate about is streamlining workflows, redesigning processes, and then creating that culture, really. And then, you try and make sure that any changes you are making are for long term. So you have to make sure that there's audits in place that are done regularly to make sure those workflows and processes are being followed. And if they're not, why not? So there's someone in charge of them. So you're supporting the practice in managing the change effectively, because there's obviously the change cycle, which everyone I'm sure will know about. There's a lot of barriers to change in that. Then you have to look at the KPIs. How can you, what KPI should be there for each process and workflow that you made, and are they being adhered to, and are you doing, are you performing well on the KPIs? And lastly, you look at the sustainability of the practice. So is the practice sustainable? Is it for the long term? And is there is there a culture of innovation, adaptability, and resilience in the practice to thrive in a challenging healthcare environment? So that's me. Sorry if I've talked a bit too long. I appreciate any questions if anyone has.
Fantastic. I'm just going to remove your slides for now. And let's get in close. We do have some questions. That was brilliant. Thank you, Dr. Mateen. We do have some questions that have come in. So I'm going to throw them your way.
Happy to answer.
Kay asks, but in all this, the individual is still sometimes lost. My surgery wants my BP presumably to tick a box, but aren't interested in my low postmenopausal hormones or checking all my bloods due to other diseases which affect maybe iron levels, etc. So I assume there's no tick box for that one.
I hope people don't get the wrong end of the stick here, because most practices are not just ticking a box. But however, to get the payment off the QOF, you have to literally tick a box. But those tick boxes are actually quality outcome framework. So you are measuring quality through that, and the tick boxes are relevant to your illness. So I don't want people to get the wrong aspect of that. Unfortunately, look, I can't comment on what your practice or your doctors are doing. It would be, for me, unprofessional to comment on something like this. I literally want to talk about what we're doing. So yeah, unfortunately, I can't comment on what other practices are doing. If you're asking me a specific question about how we're doing things, I'm happy to kind of answer those.
There's just a comment here. I feel sorry for doctors having to type like mad during consultations. It can also mean that important clues are missed. Don't suppose there's a way around that yet?
Sorry, say that again. Sorry, I didn't hear that.
So the comment is, I feel sorry for doctors having to type like mad during consultations. It can also mean that important clues are missed. Don't suppose there's a way around it?
Great question. Great question. Because I think we've had this issue with our doctors who are training to become GPs, and they often say we don't have enough time. We can't listen to the patient and type. And if we're typing, then we're not really listening to the patient. The patient will know we're not fully listening to the patient. So I agree with that point. But there are really great products out there, and I'm not going to name them because I'll be unfair. But our doctors are using AI generated tools, which essentially you literally have a conversation with your patient. You can look at the patient, you can make sure you pick up on all the clues, visual or auditory, and you literally have a conversation, and this AI tool will write your whole consultation down in a way which makes sense, and it's concise. It's not literally every single word. So there are tools out there, and I would like all the clinicians listening to this, I'm sure that some of the clinicians are aware of them, to use them as much as possible, because at the end of the day, I think you're losing something if you're not actually listening, not just listening to the patient, but actually looking at the patient if they're in front of you. Yeah. So great question.
Yeah. And that, Kay mentions nonverbal, cues. Absolutely, because, if we're not looking at someone, their body language may be giving something away, their voice tone, all of that.
Yes, completely agree. So a consultation should never be just someone listening. It needs to be non-visual aids as well as picking up, sometimes the expressions of patients, especially, someone might come in with not feeling well, possibly low in mood, anxious. So you're looking at non-verbal cues there. So very important. I think she's mentioned something about, are these tools accessible? They are very accessible. Unfortunately, as you can imagine, I can't name the tools. They are free as well. So if you just type those on Google or any other platform, I'm sure you'll be able to find these tools, and they are readily accessible.
A couple more here, and I've got a couple for you as well, if you don't mind. Question. So just a comment. So in this model, are patients and doctors communicating through headphones? You're talking about having good quality headphones. Tell us a bit more about that.
So we have extremely high percentage of face-to-face appointments. So in the hub, the partners, if they're deciding which patient should be seen by which clinician face-to-face, then we sometimes give a quick call to the patient. Okay, very small clinical aspects would be shared via phone call anyway, because above 90% of our consultations are face-to-face. But even if it is a consultation, let's say someone wanted, for example, a sick note, and you're discussing with the patient if the sick note is required or not, or how long, you might be talking to them via headphones as a telephone consultation. So we made sure we bought high quality headphones that the patients cannot hear the background and no one outside can hear what the patient is saying as well. Primarily confidentiality, really.
Yeah, absolutely. Eliza, I hope I'm pronouncing your name correctly. It's one of those two, isn't it? What kind of medical tests do you do to diagnose vulvodynia and all the possible causes of that? So just to step in there, you're not going to be diagnosing that. You're going to be referring someone on. But what would you say to someone presenting with vulval pain?
I think the biggest thing as a GP you have to do is, first of all, listen to the patient. Okay, so make sure the patient is listened to. You try and understand where the patient is coming from. You ask questions appropriately around the subject, and if it is pain, you ask them, how did this pain start? How does it make them feel? Does the pain go anywhere? How intense is the pain? Does anything make the pain worse? Does anything make the pain better? I think the next step after getting a full detailed history, including past medical history of the presenting complaint, and maybe adding aspects of it, as any family history of certain pains, or have you talked to anyone about this pain? What were your ideas about the pains? Did you have any concerns? And what the expectations of the patients are as well. I think that's really, really key. You have to kind of think of yourself as a patient. You have to try and address the patient's concerns rather than as a doctor your agenda sometimes. And so the next step after that would be essentially examination. If you feel that examination is required, or the patient would and you think that would help, you have to examine the patient with the chaperone being present, and following that you would make a plan. Now, as a GP, you're not an expert, you're not a gynecologist, so you won't be able to sometimes 100% find out the cause of why the pain is happening. But so I wouldn't be able to say which exact test would be required. However, after the examination, you might be able to pinpoint where the pain is coming from and possible causes. But it's a very generic question.
It is. And look, certainly it's a case saying GP is usually our first port of call when we experience vulval pain. Absolutely. Oh, she says, would a conference with the Vulval Pain Society perhaps be a good idea, or a workshop? Thanks for that, Kay. I know that vulvodynia knowledge isn't all that great in midwifery, for example. Do you think all your staff have heard of vulvodynia? I still speak to healthcare professionals who have not heard of it. I mean, this is a really good point. When we were talking with Athena Louncey last year, and her research showed that really, half of patients eventually give up at the GP stage because repeatedly they're told, things like it's all in your head, have some wine and it will go away. Things that we heard 20, 30 years ago are still happening. So there is, seemingly seems to be a void here in knowledge that needs to be filled. Something needs to happen, especially as anyone watching this, if you're watching live or on the replay, if you're experiencing vulval pain, please know that it is common. 1 in 7 vulva owners will experience vulval pain at some point in their life. That is very, very high. So we do want to get diagnosed as early as possible, so we're on a treatment pathway. Your GP on examination, if they see any kind of skin issues, ideally will be, referring you to a vulval dermatologist, otherwise a gynecologist, and also check out the BSSVD clinics on their site. You may potentially go into your GP, and I like the way you said, as a GP, you want to meet a patient's expectations. So in 10 minutes, there's a lot to do, isn't there, for you? So if you go in prepared, if you check out our website, there is a sheet that you can actually prepare before you go in for a consultation, whether that's with a vulval specialist, but you can use that template before you go to your GP too. So you know what you're going to say, have these bullet points down. You have expectations, so you leave there with something. So I know that sounds like the onus is on you, but going in there with an idea of, okay, I need something today, would be helpful. I have a quick question for you. You mentioned in 2019 you had 4,700 patients, and this has gone up this year to 11,000. How are you coping with that? What has your practice increased in size in terms of GPs? How are you able to serve this increasing number of patients and still be the number one rated GP practice in the UK on Google?
Yeah, no, great question. Thank you for asking that question. So we're 12,200. So we have gained exceptional amount. And so I think I remember, so when it was 4,700, there was only 3 clinicians, 3 doctors who were working. And now, as I mentioned, they're about 12 or 13. So it's gone up from 3 to 13, even though the list size has gone up 3 times, but the amount of clinicians serving have gone up 4 times, for example. So and I think the biggest, the hardest thing to do is when a business is growing to maintain the quality or the level of quality of care. And I think we knew that was going to be not easy, but we wanted our reputation not to be undermined, and we wanted to further increase our reputation. And luckily and thankfully, our reputation has increased every single year through the NHS patient survey results. And we ensured that happened by making sure we hire colleagues, doctors, nurse practitioners, etc., but mainly doctors, in advance. So we would project, and that's one thing I brought in, we would project where our list size would be maybe in 6 months' time, and we would make sure we have excess appointments now for the future. And that would mean that our doctors, sometimes their appointments wouldn't fully get used, and that's extremely rare in GP, because in most practices have completed or filled their appointments by 9 a.m. So after that, you have to go to urgent care center, A&E, etc. But we overhire to make sure that our patients are never disappointed. And I think our patients appreciate that. Our staff really, really appreciate that, because they don't have to have these awkward conversations with patients to say, unfortunately, we're full, please go to X, Y, and Z. So, and as a business model, thankfully, it's working as well.
Good. Okay. The other point you mentioned was your satisfaction scores. And I want to talk to you about reception, because we hear often that people can't get past the receptionist. So you've put down the helpfulness of reception and admin staff is at 94%. Now, I know admin and reception is not your area, but how is it that your receptionists are perhaps more amenable? Because one of the things we hear most commonly from people is, I can't get past reception. They're asking me questions that I don't feel happy answering. They're not the GP. What's happening with your reception staff?
Yeah, so I just want to start. Thank you for asking that question. I just want to start by answering this question by saying, in my opinion, the hardest job in a GP practice is the receptionist. It's not an easy job. I definitely couldn't do that job. And I think so. We always had the motto in our practice: how can we make the hardest job in our practice like one of the easiest jobs? Like, how can we make it easier at least? And I think the biggest hurdle receptionists face is patients. Why do patients call a GP practice, or why do people who own a car go to a mechanic? Is they want to see a mechanic, they want to see a GP, or they want to see a clinician. That's what they want to do. So to make their job easier, you have to make sure there's enough appointments available. So they don't have to get in awkward conversations with patients. They have an appointment, they give the appointment to the patient. The patient's happy, reception's happy. It doesn't take too long on the phone line, and the next patient can be you can answer the call of the next patient. So again, one thing we have done is, again, improved access. Access isn't everything, but if you improve access so the patients get heard and get to talk to a clinician, most of patients' concerns will go away. Most of the behavior you sometimes see from patients towards a receptionist, which is, I believe, sometimes is unfair, is because they don't get to talk to a doctor and they feel the receptionist is blocking it. But a lot of the time, unfortunately, it's because The receptionist wants you to talk to a doctor. They're not trying to be difficult, but there's maybe not an appointment available. And that's what we've tried to rectify.
Yeah, your triage system obviously works well for you, that you can see people on the day. Yeah.
Exactly.
Do you also use automated booking like patient access? I think it's great for some, but too hard for others to use. I think you do, don't you, on your website? Do you have online?
Yeah, we have 24/7 online, 365 days a year. So if you wanted to book an appointment right now for tomorrow morning, you can go on our website and you can log in through, I think, the NHS app, and you can make an appointment tomorrow morning. No problem. And even on a bank holiday, you can make an appointment for the next day we're in West.
Lovely. So how easy is it for someone how quickly do people get through? Because again, another thing people say is they phone up the GP practice and they are maybe 10 or 20 in the queue. What's happening there? Do you have enough staff to field those calls first thing in the morning? Or is it that because you can fit people in that day, people are phoning at different times?
Yes, exactly. I think that you've kind of answered your question. So if you have a practice which has limited amount of appointments available, everyone will want to call at 8 a.m. when the practice opens. So it clogs up the system. People are then left waiting for 10 minutes, 20 minutes, half an hour, or the phone might cut off as well. When patients slowly find out that you don't have to call at 8 o'clock, you can call 10 o'clock or 12 o'clock if you want to, and you will get an appointment as soon as possible as well. They don't clog up the system because then they don't need to, number one. Number two, if the receptionists know that they're not going to be triaging, they're not going to be making medical decisions, it's up to the partners to make those decisions. They literally will ask your name, age, make sure the date of birth is correct, and ask roughly in one sentence what the issue is, and then leave the clinical job for the doctors to do. So that conversation normally takes a minute and a half. So that means that the next patient in line can get through a lot quicker. So our waiting times are, I would say, extremely minimal. If you're asking for data, unfortunately, I can't give you the exact time, but I would hasten to say not many people ever complain getting through the receptionist in our practice, luckily.
Good to hear. Good to hear. Any more questions for Dr. Mateen, please pop them up. And for whatever reason, my phone decided to try and answer that question. I'm going to... Sorry, people. Any questions for Dr. Mateen? I was going to ask, if people watching the replay have questions, would you be happy to pop on our Facebook page and have a look at them? We'll sort of maybe send a batch to you or something for you to answer, and we can answer on your behalf, or you can pop along to our Facebook page. Would you be happy to do that?
Happy to do that. You can also link with me on LinkedIn as well. But yeah, happy to join in my Facebook session as well if required.
Wonderful. Brilliant. Any closing thoughts, Dr. Mateen?
I think just to kind of say thank you for inviting me. Thank you for raising awareness, because I'll be honest with you, I have gained so much information from your website, from your knowledge as well, and I think you're tapping into people's concerns, which are not often heard about and not many clinicians know about. So I certainly have promoted your website, just so clinicians, not only patients, but clinicians get to know more about Virginia as well. So thank you for inviting me, and thank you for raising awareness.
Thank you. Thank you so much. And for anyone who joined late, you can rewatch this live stream or any of our previous ones on our Facebook events page. Sorry, Catherine, I should have mentioned Catherine is in the background. Catherine from our management team is in the background. So Catherine, if you can pop up the link for our Facebook to live streams that can be watched, or we'll pop them up later. Also, a full playlist of around 46 video replays is on our YouTube channel. So look, we have spoken with vulval pain experts, different clinicians and researchers. You can find them all in that library on YouTube. We've covered a lot, so you can catch up with best practice in treating vulvodynia, multidisciplinary care. We've done Q&As with experts, preparing well for appointments, as you heard me talking about earlier, physiotherapy, vulval skin conditions, psychosexual medicine and intimacy with vulval pain, pain science and calming the nervous system. No guesses for guessing who did that one. Supporting self-management of pain, menopause, yoga, lots of stuff. Pudendal neuralgia, Marion is in the background there. That one was with Marion. Lots we've covered. Please, before I tell you who's coming on next, because we do have another live stream in a couple of weeks' time, please bear in mind, we are a small team of volunteers here at the Vulval Pain Society. We all work in some capacity in the field of pain with patients, training clinicians, so please be patient with us if you contact us. We may not reply as quickly as you might like us to, but please bear with us. You will get through. We will reply. By the way, we are looking for another volunteer who might take care of our social media marketing. So if you or someone else you know may be able to help us, reach out and let us know. Okay, next time, Junior Dr. Harriet has a lived experience with vulvodynia, and she's going to be talking about her road to recovery. And the lovely thing about Dr. Harriet is that she is raising some funds for us by doing a half marathon. Bear in mind, she used to live with vulvodynia, so this would have been unthinkable. So tune in. That's 7 p.m. Tuesday, the 24th of September. So a couple of weeks' time. Please share our videos, our posts far and wide with anyone you think can benefit. You heard me say 1 in 7 vulva owners will experience some kind of vulval pain in their lifetime. And we need clinicians to know more about this too, not just expert clinicians, but everyone. So do share far and wide. We're on YouTube, Facebook. Yeah, we're sort of on Twitter. We're now on Instagram too. Thank you for everyone who is already promoting and sharing our stuff and commenting. We're really, really grateful as you are helping us help you better. So, last but not least, Dr. Mateen, you mentioned our website. We do have a whole bunch of resources on our website too. That our website details will be going up on our comments as well. Look, that is all from us today. Thank you so much for joining us live, and thank you for watching the replay if that's what you're doing. Dr. Sheikh, Mateen, Ellahi, thank you so much for your time and a really informative session today. Thank you so much.
Thank you very much. Thank you for inviting me.
Right. Bye for now. Keep in touch and see you all in a couple of weeks' time. Cheerio for now. Bye-bye.